so I'm really glad you're here. I'd like to take a moment to introduce our speakers, and then I'll turn it over to them to kick us off. So our first speaker is Dr. LauraEllen Ashcraft. Dr. Ashcraft's an assistant professor of epidemiology in the Department of Biostats, Epi, and Informatics in the Perelman School of Medicine here at Penn. She's also an implementation science methodologist in the Center for Healthcare Evaluation, Research, and Promotion, or CHIRP, at the Corporal Michael Crescents VA Medical Center in Philadelphia, and serves as the co-director of the Dissemination and Implementation Science Core there. Dr. Ashcraft's work as an implementation science methodologist seeks to advance the field of implementation science by leveraging theory to promote equity, excellence, and innovation in methods, analysis, and dissemination in health and human services. So we're thrilled to have her as part of our PICE team. And then she also is joined today by Caitlin Reardon. We're so glad that you're here to join us, Caitlin. Caitlin's faculty in the MS Master's Program in Implementation Science at the Geisel School of Medicine at Dartmouth, and an implementation scientist and qualitative methodologist at CHIRP and the VA Pittsburgh healthcare system. She's one of the developers of the updated CFIR and CFIR Outcomes Addendum and User Guide. She worked really closely with Laura Damschroeder, the lead developer of CFIR, over the years, and has tons of experience using CFIR and training others and working with others to apply CFIR both nationally and globally. So we're really thrilled to have you both here today. And I'll turn it over to you to do any housekeeping items around how you want to handle questions and that, and to kick us off. So thank you.
Welcome, everybody. Thanks for having us. Welcome to this workshop. So LauraEllen and I are going to be facilitating today, but this slide actually lists all the members of our CFIR leadership team. During the workshop today, we'll have 2 breaks for questions during the workshop and then a final Q&A at the very end. So if you would like to put your questions in the chat, we will pause 3 times to answer those questions. I think that's the only housekeeping items. LauraEllen, anything else?
Yeah, we're going to keep everyone muted today just because we have a large number, but please put questions in the chat. We have multiple folks who will be keeping an eye on it. And so the goal here is to help you to understand CFIR and how to use it. And so if you have questions, please ask them. That's one of the reasons why we're so passionate about bringing this work to all of you.
All right, perfect. I also do want to say before we get going that these are our views. These are not the views of the United States government. So what is the Consolidated Framework for Implementation Research? CFIR is a determinate framework. That means that its constructs, or the factors within it, determine or influence implementation at the inner setting or the organizational level. It was originally developed by Laura Damschroeder and implementation researchers affiliated with the Veterans Affairs back in 2009. And the original CFIR was based on 19 theories, models, and frameworks. So for example, Green-Halsh's systematic review of the diffusion of innovations in service organizations was included. It was developed because when comparing the existing theories, models, and frameworks, it was found that 1, constructs overlapped or were missing, and 2, terminology and definitions were not consistent. So constructs suffered from jingle-jangle fallacies. In other words, similar labels were used to describe different underlying concepts, or jingle, while different labels were used to describe similar concepts, or jangle. And although CFIR has been one of the most commonly used and cited determinate frameworks, as implementation science advanced, updates were needed to the framework. As a result, we conducted a literature review with a systematic search for articles published between 2009 and July 2020 that included CFIR in the title or the abstract. That pulled 376 articles, 59 of which included feedback on CFIR. But there was actually really limited feedback in the published articles. So we also sent a survey to the corresponding authors of the articles asking for feedback. We then combined the data set to identify themes and use consensus approach to finalize all the CFIR updates. Updates to CFIR overall serve to clarify the scope of the framework, to broaden language beyond healthcare, and address any gaps in determinants. And I highly recommend reading the additional file 5 of this manuscript. It maps the original CFIR constructs to the updated CFIR constructs, but it also provides a rationale for each update based on the user feedback. So you'll know what we changed and why we changed it. And this file will also be really indispensable for folks that, maybe started their project using the original CFIR, but want to go forward with analysis or with publication using the updated CFIR, which is what we do recommend at this point. So a really frequent question we get as a team is how CFIR can be used in implementation science. And to answer this question, we like to first think about the innovation pathway generally from development to evaluation. So in science, we develop an intervention, we implement the intervention, we evaluate the effectiveness of implementation. So, we determine, was implementation successful and why or why not, right? What were the barriers and facilitators to implementation? And then we also evaluate the effectiveness of the intervention itself. So determine if the intervention did in fact, have the positive clinical impact, for example, on patients. This is super oversimplified. This process is iterative, but we wanted to start here to highlight that CFIR was designed to help with step 3 on this slide, where it helps researchers or practitioners understand why implementation was or was not successful. So in other words, the primary use and purpose of CFIR is to predict and or explain implementation outcomes by assessing CFIR constructs. But folks come to us a lot and they want to use CFIR in other ways. But in order to use CFIR in steps 1, 2, and 4 of this pathway, it would need to be adapted and integrated with another theory model or framework. So for example, if you want to use CFIR as part of your innovation development approach, that would require integration with an innovation development framework. So for example, intervention mapping. Because most intervention development approaches include assessing context, having a baseline understanding of context. So CFIR can be used to complete that part of intervention development. Some people refer to this as designing with implementation in mind, or designing for dissemination, or D for D. For using CFIR in implementation planning, you need to integrate it with a process model to guide the implementation process overall. So for example, getting to outcomes. However, again, like most intervention development frameworks, most implementation process models also include assessing context. So CFIR can be used as part of that process to identify barriers and facilitators that need to be addressed by implementation strategies. Lastly, using CFIR in hybrid studies or research that evaluates both implementation and intervention effectiveness requires integration with another framework to identify and measure intervention effectiveness determinants and outcomes. So for example, PRISM, but CFIR can still be used normally to evaluate the implementation determinants. While CFIR can be used in these other ways, the focus of this workshop and our recent user guide is focused on using CFIR specifically in implementation research. I'll now briefly go over all 5 steps for using CFIR in implementation research, and then in the later part of the presentation, we're going to do a deeper dive into the first step, which is CFIR and study design. I know there's a lot of text on this slide, and really our overarching goal with this is to just provide an outline of what's included in the manuscript, and more importantly, to highlight the tools and templates that we have available as additional files in the manuscript, which will also be very, very, very soon on our updated website. So basically, you'll have access to these tools when you go forth and use CFIR. The first step is study design, where you define your research question and implementation outcome, and you define your CFIR domains. For that, we've developed a worksheet to help with that process. The second step is data collection, where you determine an appropriate data collection approach, develop a data collection instrument, develop a sampling strategy, and then conduct your data collection. And we have developed the CFIR construct example questions, which can guide development of your data collection instrument. The third step is data analysis, where you determine an appropriate data analysis approach and conduct your data analysis. We've developed several tools actually to help with this step. So the CFIR construct coding guidelines are the basis for your qualitative codebook. Of course, those need to be operationalized and updated for your project, but we've given you a pretty good starting point with coding guidelines, including inclusion and exclusion criteria for coding. The inner setting memo template helps aggregate data across all participants for a given inner setting. That helps you summarize and then ultimately rate your determinants if you're choosing to do so. And then last but not least, the CFIR construct rating guidelines help quantify CFIR constructs as either weak or strong barriers or facilitators to implementation. The fourth step is data interpretation, where you align your data on your implementation determinants, including those ratings that you potentially created, and your implementation outcomes. You can then determine an appropriate data interpretation approach to identify those constructs that are difference makers or constructs that distinguish between settings with low versus high implementation success. Once you know your difference makers, you can then, of course, target those constructs with strategies. We have developed a CFIR construct by intersetting matrix template to help you aggregate data on determinants and outcomes. The fifth step is knowledge dissemination, where you plan your dissemination and then you go forth and disseminate your knowledge. For detailed information on completing each step and access to the tools, like I said, you can go to the manuscript, which is open access, or to our website. The information is mostly there now, but will be even more detailed and up to date very soon. We're talking within a couple weeks. I'm bummed that it's not ready today. So in order to complete step one, right, and design a study, we first need to understand the CFIR domains. And so I'm going to turn it over to LauraEllen to discuss those.
Hi, everyone. It's so good to be here and be sharing this incredible work with you, with our Pisces family. And I'm so glad that I convinced Caitlin that she should come and talk to us here at Pisces. And I know there are lots of Improve and VA folks here as well. So welcome to every one of you. So as Caitlin mentioned, let's begin by talking through the CFIR domains. So the updated CFIR contains 48 constructs and 19 subconstructs across 5 domains, with 1 domain including 2 subdomains, which we're going to go over all of this in a bit. These constructs are determinants to implementation success in the inner setting, which is typically some kind of intervention, but varies based on your particular research question and setting. So the first domain is the innovation. Think about Rogers' classic diffusion of innovations theory, which defines innovation as the idea, practice, or object that is perceived as new. It's a really important part, perceived as new by an individual or other unit of adoption. This is a very broad definition and includes any of those things. If we remember Jeff Curran's paper from 2020, the thing being implemented. We then move to the second domain, which is the outer setting. And this is the setting within which that inner setting exists. The third domain is the inner setting itself. This is the setting where the innovation is being implemented. When we think about analyses using CFIR, this is our unit of analysis. The fourth domain is the individuals. This includes the roles and characteristics of individuals involved with implementing, delivering, and/or receiving the innovation itself. The fifth domain is the implementation process. And so what this domain includes are the activities and strategies used to implement that innovation or thing. Next slide. This, there we go. This diagram is our updated CFIR figure, which if you were at the DNI conference, we handed out lots of stickers, and I have more for folks who will be at Penn in the near future. So this diagram illustrates how the domains are related to each other. You can see here that the innovation is implemented by individuals in the inner setting, which is also within that outer setting, and the implementation process works around all of the other domains. And so this is the order that we're going to dig into each of the domains a little bit more. So let's start with that innovation. The constructs in this domain are the characteristics of that innovation or thing that is being implemented. So for example, innovation evidence base, which is a construct, captures the extent to which the innovation itself has robust evidence supporting its effectiveness, while innovation design captures the extent to which the innovation is well designed and packaged. And so if we think about if implementation fails, we need to know if it failed due to the characteristics of the innovation, So maybe the innovation itself was poorly designed, or if it failed due to the implementation process, maybe the implementation process was poorly planned. And so for this reason, we really encourage users to clearly distinguish between the innovation itself and the implementation process or strategy that you're using to implement the innovation. This is necessary for accurate attribution to implementation outcomes and to identify appropriate areas for future intervention. Next, we're going to go to the individual's domain. So the constructs in the individual's domain are the roles and characteristics of the individuals implementing, delivering, and or receiving the innovation. So for example, for high-level leaders, motivation captures the extent to which they are committed to supporting the implementation, while the implementation leads, opportunity captures the extent to which they have the availability, the scope, and the power to lead that implementation. Next, we're going to go to the inner setting. The constructs in the inner setting domain are the characteristics of the inner setting itself. And so, for example, relative priority, which Caitlin and I both think is incredibly important in this work, relative priority captures the extent to which implementing and delivering the innovation is important compared to other initiatives, while access to knowledge and information captures the extent to which guidance and or training is accessible to implement and deliver the innovation right within that inner setting. It's important to note here that some implementation efforts may have multiple inner settings and then multiple levels within the inner setting itself. Next, we're going to go to the outer setting rather. The constructs in the outer setting are the characteristics of that outer setting. So, for example, partnerships and connections captures the extent to which the inner setting is networked with external entities, while financing captures the extent to which funding from external entities is available to implement and or deliver the innovation. You can see there's lots of interactions between these concentric circles. It's important to note that while these constructs originate in that outer setting, they influence implementation in the inner setting. In addition, similar to the inner setting, there may be multiple outer settings and or multiple levels within your outer setting domain. And finally, the constructs in this domain capture the core activities and strategies used to implement the innovation. So for example, planning captures the extent to which individuals identify roles and responsibilities, outline specific steps and milestones, and define goals and measures for implementation success in advance, while engaging innovation recipients captures the extent to which individuals attract and encourage recipients to serve on the implementation team and or participate in the innovation. Generally, the constructs in the implementation process domain have always roughly mapped to the PDSA cycles or Plan, Do, Study, Act model. So we're now going to do a bit of a deeper dive into CFIR and study design by participating in an activity together to define the domains. And so what we're going to ask you to do is to participate by putting your responses in the chat. And what I'm going to do, I'm going to copy and paste this description of our innovation into the chat as well, so that you can refer to it as we move through the process. And so this is our fictional example for our workshop. So I'm going to read it briefly, and then we're going to walk through defining each of the domains for this specific example. Okay, so the health promotion and disease prevention coordinators at 7 VA hospitals in VISN 30. Now, VISNs are regions of the United States that work together on various efforts. So just think of VISN as a region, such as the Northeast, for example. Okay, so at 7 VA hospitals in VISN 30, we'll be using Getting to Outcomes to lead implementation of an intuitive eating class for veterans with binge eating disorder. The class will be 10 weeks long, in-person based class in the based on the intuitive eating book and teaching non-diet self-care eating framework, which integrates instinctive, emotion, and rational thought. Intuitive eating is a health at every size, evidence-based model with a validated assessment scale, the IES-3. Primary care and mental health providers will refer veterans to the class, which will then be delivered by registered dietitians. Okay, so this is the example that we're going to use as we go through and define and practice defining each of the CFIR domains. So let's go to the next slide. So here are each of the CFIR domains that we just defined together. So first, we're going to begin with the innovation. So that yellow line at the top. So please put in the chat, what is the innovation in our fictitious example? What is the innovation being implemented and evaluated? What are its components? What are some of the features of that innovation? And where would you say is the boundary between the innovation and the process or strategy that we're using to implement that innovation? So, right, we really think about in the CFIR verse, we think about this boundary generally as what stops and what continues. So the implementation process and strategies may end, but right, our goal is for sustainability, right, for ongoing use of the innovation. And so then the innovation part continues indefinitely. All right, so please feel free to put in the chat what you think the innovation is. So we have one person, intuitive eating based program. Oh, wow, so fast. This is excellent. The class, intuitive eating class. Yep. Okay, the 10-week long in-person based class. Yep, capturing some of those core components of that class. This is looking great. Well done, everyone. Yes, and I will tell you, we use this example, and I think Caitlin and I will both say that when we work with folks who are not just in their use of CFIR and their application of CFIR, but sometimes it's really tricky to differentiate between what your innovation is and what your implementation process is, what implementation strategies you're using. Very, very good, everyone. All right, so let's go to the next slide. And so, yes, as everyone said, we think about in our example here, our innovation is the intuitive eating class, right? And so as we've said already, and we'll say it multiple times, when you're using CFIR, it's really important that you clearly document what is the innovation being implemented, creating those boundaries between the innovation itself and the implementation process. And so things you might want to think about is the innovation type. What are those core versus adaptable components? Folks who have heard me lecture or talk before, you know that I care a lot about this, core and adaptable components. And then thinking about the functions and forms, right? And really thinking about all of these things, which is unique to every single situation and implementation effort that you're doing. And really using published reporting guidelines that are out there for the field of implementation science is really, really helpful and important to the field as well. Okay, well done, everyone, and excellent on all of the participation. So I expect great things for the rest of our time together. Okay, so let's talk about the outer setting and the inner setting. We're going to define these two domains. So this is our second line, our green, and our third line, our red. A little behind the scenes story, Caitlin and I worked very hard on this color. I should say Caitlin worked hard on this color scheme and I gave lots of feedback. So we're very excited to roll this all out to you and also for our new website to be out in the next couple weeks. We're so close. Okay, so let's define our outer setting and our inner setting. So thinking about where is implementation and delivery of our innovation, right? Our intuitive eating class, where is that occurring? And then thinking about what is the boundary between the inner setting, which we think about, right, as our unit of analysis and location about where the innovation is being implemented, and then that outer setting, so the area outside of the inner setting. Okay, so put it in the chat, thinking about the outer setting and inner setting. Great, I'm seeing some responses. Outer setting, the VA healthcare system. Vision 30, enter the VA hospitals. Yep, outer setting, inner setting each VA hospital. Yeah, perhaps the VA system in the US overall. Yeah, great thought there, Hannah. VA hospitals, yep. Great. Yes, Martha, great point here, thinking about that outer setting being that larger region, that policy environment. Absolutely. VA hospitals, Vision. Great, great. All right. Any observations from the chat that you may have? Caitlin, I know you're balancing multiple things, sharing the slides, the VA hospitals. It's also so great to see so many familiar names. So hi, everyone. Thank you so much for coming. Go ahead, Caitlin.
No, I'm just loving the level of participation. This is so fun. I'm like rapid reading, speed reading.
Yeah, speed reading.
So this is, I think, one of the harder sometimes domains for people to define, because at the end of the day, it sometimes isn't clear and it can be flexible, right? It needs to be defined in a way that makes sense for your project. And what we always go back to is thinking about the unit of analysis. And so if you look at that, the example that we gave, right, the idea with this is that, we're being funded to compare outcomes across the 7 hospitals. And so by saying we're going to be comparing across the 7 hospitals, each hospital becomes our inner setting or our unit of analysis. And so everything outside of that, so Vision 30, the local communities, the state, the country, et cetera, become that outer setting. So when in doubt, go back to whatever your unit of analysis is and where you're sort of hoping to compare outcomes.
Yeah, thank you, Caitlin. So let's go to the next slide and we'll share our definitions. So yes, yeah, the inner setting is each of those VA hospitals, and then the outer setting is everything outside of the hospitals, just like Caitlin said. And the example that we provided here is quite clean cut, right? Like it makes sense. And also I recognize that for many of you, your projects are not so clean or not so obvious what your inner and outer settings are. And so I think Caitlin's comment about your unit of analysis and really thinking about what makes sense for your project and what definition is going to best help you to answer the research question that you're asking, I think is also really important. And understanding that sometimes it may feel a little artificial to the larger real world, but really going back to what is your research question? What is your unit of analysis to answer that research question, and then go from there. And so again, really thinking about when you're using CFIR, we define your inner setting that you have based on your unit of analysis. And so in this case, right, we're comparing those VA hospitals. And so in addition to guiding analysis, right, clearly defining the inner versus outer setting is really, really important because it can help us to accurately attribute outcomes and to figure out at what level and type of intervention might be needed to address a barrier. So for example, was a barrier at the inner setting level, which may theoretically, right, be addressable. If something's happening at one of the 7 VA medical centers, right, that may be a bit easier to address versus if a barrier is happening at the outer setting level, right, at the policy level, yes, maybe long term we can think about how to address that, but in the immediate short term, that may be a bit more complicated. Excellent. All right, so let's go to the next slide. Next, we're going to dive into individuals. And so really thinking about who are the individuals, and this is our orange bar, thinking about who are the individuals involved with implementing, delivering, and or receiving the innovation. And so are there any folks that are indirectly involved with delivery or receipt of the innovation? So really thinking about providers who are indirectly delivering the innovation, and patient caregivers may be indirectly receiving the innovation, right? So what are their roles and what are their relevant characteristics, right? This is where we have our subdomains. And so this, just to note here that this list of people is not the same as the folks with whom you would collect data using CFIR. We're going to get into that in a little bit. And so first we want to think about how we are defining the roles. So really thinking about who are the people who are delivering, receiving, or implementing your innovation. And so let's, using our example, which I know is now a bit further up in the chat. And so maybe I'm going to recopy it for folks so you can see it. Think about
I can
oh,
bring it down for you.
oh, there we go. I got it. So who are the roles of people? And then we'll get into their characteristics on the next in the next section here. So who are some of the roles? Okay, I'm seeing some responses. Thank you so much. Yes, it's so great to see names who I know of folks. Welcome everyone. Okay. Great. Yes, the primary care and mental health providers, the coordinators, the dietitians, the veterans with binge eating disorder. Yeah. Other folks here, registered dietitians delivering, veterans receiving. The referral pathway for many of us who work in physical healthcare settings and even behavioral healthcare settings, the referral pathways is really, really important and something that we don't want to overlook. Absolutely. Other thoughts that folks have? This is so great. We're doing
And how, I would be curious how familiar folks are with the roles in CFIR and if anyone's able to map, the roles within the hospital to the role in CFIR. So for example, in CFIR, there's a role called implementation leads, and those are the folks that are in fact leading implementation. So just be curious. And it's obviously okay if you're not familiar, but I was curious if anybody could map them.
Yeah, so who would be the implementation leads, for example, in our, okay, great. Thank you, Jacqueline. Implementation recipients, those, yep. Thank you, Martha. Yeah. Great. All right, let's go to the next slide and we can talk through it a little bit. All right, so this domain is a little bit trickier because we have those 2 subdomains, right? So in the individuals domain in the updated CFIR, right, has these 2, the roles and characteristics. So we're going to talk through the roles first, and then we'll spend a bit of time and dig more into the characteristics. So as Caitlin alluded to, right, we think of the high and mid-level leaders, right? These would be hospital directors. In VA, we have someone called the Associate Chief of Staff of Primary Care. So that's a pretty high to mid-level role, depending on at what level you're implementing. We think about our implementation leads, which some folks got in the chat, right? The coordinators who are leading the implementation. the deliverers, right? The deliverers of that innovation are those registered dietitians, right, who are leading and delivering the class. The indirect deliverers, I think, as folks have started to get to there, right, are the primary care and mental health providers who are referring to the class, right? I saw some comments about that referral pathway. The direct recipients may be, right, are those veterans with binge eating disorder who are attending the class, and then indirect recipients are caregivers of those veterans, right, who are attending the class. Yeah, absolutely. And so if we go to the next slide, we're going to talk a bit about the characteristics. And so the way that CFIR was updated in 2022, we swapped out some of those previous items that were in the original CFIR with the COM part of COM-B plus thinking about need. So let's talk through this slide in a bit more detail. So capability, opportunity, and behavior, COM-B. Can folks put in the chat, are people familiar with COM-B? I know in some circles of implementation science, COM-B is very much centered and at the forefront. In other spaces, it's less centered. So when I first came to implementation science, when I first came to implementation science, I was not, this was not kind of the core part of my initial understanding of implementation science, but I know that's not true everywhere. Okay, so it looks like, at least for folks who respond, we're about 50-50. Okay, after learning about CFIR, oh, I love that, right? CFIR is the pathway to all other fun things implementation. Awesome. Okay, so COM-B is a theory that really thinks about individual level behavior change. And COM-B is anchored in this idea of behavior change. And so the way that COM-B works is that it really says that in order for people to change, in order for behavior to change, they need to be capable of the change. So they need to have the knowledge and skills that will lead to that change. They need to have the opportunity, so be in an environment that supports that change. And then they also need to have the motivation, right? And so this is where the COM comes from. And so then when we're thinking about the COM as it relates to the characteristics within the individual's domain, do we want to go to the next slide here? We can really think about the need, the capability, the opportunity, and the motivation in terms for each individual being able to complete their role as it relates to our innovation, right? Our intuitive eating class. So, for example, do the implementation leads have the capability and the motivation, and have they been given the time and the authority to lead implementation, right? Thinking about all of these factors as it fits into really thinking about that also within that implementation process related to that innovation in the inner setting, right? You can see how all of these things work together toward getting an evidence-based practice into practice. And so overall, it's very important to document the characteristics applicable to the roles in the project based on COM-B or role-specific theories. So, for example, theories related to behavior change, like the theoretical domains framework, may help to provide constructs more relevant for innovation recipients and innovation deliverers, while theories related to facilitation and project management may provide constructs more relevant to external implementation facilitators and implementation leads, while theories related to leadership may provide constructs more relevant to high and mid-level leaders. And so these role-specific constructs can then be mapped to the broader COM-B constructs. So for example, all 14 domains of the theoretical domains framework map on to COM-B. So as we're thinking about the characteristics of individuals, Maybe in the chat, I have been seeing that we already have some questions primed for our upcoming Q&A section. And so we will definitely be sure to flag all of those coming up in a few slides. As we're thinking about the individual's domains and characteristics, as we thought about those individuals, the roles, how might we think about factors related to the need, capability, opportunity, and motivation of those roles for our example? If a person has negative attitudes and beliefs, they won't be motivated. Definitely. Other thoughts that people have around this? All right, so what are some factors around capability that various roles may have? Yeah, we have some good questions coming in. Okay, may need to assess baseline attitudes and beliefs. Providers may not be motivated to take extra time to talk about referrals. Yeah, do you use this for all individuals? I think there are some resources. Yeah, okay. Have they been educated to deliver the innovation? Yep.
Should we pause and answer the questions that are specific to this?
Sure, yeah. Do you want,
Before we
I
move
think
on?
you flagged a couple of them.
Yeah, definitely.
Do you want to go
So
ahead?
it's really interesting. Generally, when we were working on the updated CFIR, the stem for every single construct initially said perceptions of the extent to which, dot, dot, dot. And reviewers nixed it, actually. They didn't want the word perceptions in there. And we ultimately came to, consensus that really with CFIR constructs, you're capturing perceptions or attitudes, these sort of subjective, quote unquote, beliefs, while also sometimes capturing objective realities, right? And the example we give in the paper is, you might be doing an interview with somebody and they talk to you about the EHR, and we can say, yes, objectively, there is an EHR that exists in the hospital, but they also might share that they think it's garbage, right? And that it's really hard to send the referral through, where we're getting at like attitudes and beliefs about, a piece of infrastructure in their inner setting. So generally, when we're thinking about attitudes, when we're talking to people, that's all we're ever capturing, right? We're capturing their perceptions or their beliefs and attitudes about the innovation, about the outer setting and the inner setting, about these individuals, and then ultimately the last domain, the implementation process. So when we added in COM-B, a lot of you are noting these relationships that might come up between constructs, and that makes complete sense. There are lots of relationships that come up between constructs. So for example, believing that the intervention is not evidence-based is very likely to influence providers' level of motivation to refer. Or if providers think veterans don't need this, right? They just, we're just going to put everybody on a GLP-1, then they're less likely to refer as well. So there's tons of relationships there. When we're thinking about COM-B for veterans within the context of CFIR, which, right, is thinking about organizational level success of delivery and implementation, we're thinking about asking providers, do you think veterans need this? Do you think veterans are capable of attending this, right? Sometimes health literacy issues come up. Do you think veterans are able to do this, right? Does the opportunity exist, right? Do we provide a shuttle and transportation for in-person classes? And lastly, are veterans motivated, right? Even if if you think they need this, do you think that they will in fact attend? Ultimately, their beliefs about veterans, including the COM components, right, related to veterans, really can encourage or discourage them, wanting to implement or wanting to deliver or refer this program. So that's kind of how those things interact or intersect with each other, if that helps. And I'm just going down and looking at the rest of the comments that came in while I was talking. So yeah, if that did not answer, I was trying to answer the questions about sort of attitudes and relationships between constructs with that. So if that didn't answer, feel free to ping in the chat again. And then I know there's some other questions I noted that are great that are not quite as specific to this domain. So I was going to circle back to those later. The last one, Corey, it said you were using both CFIR and COM-B. That, COM-B is within CFIR now and is often used, but some folks are also using COM-B to collect data from, in CFIR language, recipients, in this case, veterans, and in which case you could be using COM-B with them to understand determinants to reach, right? Do they decide to participate or not, as well as effectiveness? Does this actually work for them? In terms of capability, it's capability to fulfill whatever their role is related to this intervention. That's for Amalia. So for implementation leads, do they have the skills to implement? For referrers, do they have the knowledge about how to do the referral? For veterans, do they have the literacy skills, right, to read the book or something like that? So it's all specific to the role. Sometimes we think about this as a matrix, right, of the individuals, and then need, capability, opportunity, and motivation are subconstructs. Yeah.
And that matrix, an example of that matrix is embedded in, is it additional file 6 of the updated CFIR? Is that the one or it's in the detailed, it's in one of the additional files at the very end. If you scroll down to the bottom, there's a example table with COM-B and the roles.
Yes. And all of our coding guidelines sort of divvy it up to show that you're thinking about these characteristics related to each role and the relevant behavior, whatever that is, that we're hoping to see from them. Would ORIC be a way to look at motivation? Possibly. It would depend. I'm more familiar with ORCA versus ORIC. So it would depend on the items within that.
Yeah. All right. Great questions, everyone. Excellent participation. We're loving this. We weren't sure how it was going to go, and so this is exceeding expectations. All right, so let's go to the next slide, and we can practice defining our last domain, the blue domain, implementation process. And so going back to our example, what is our implementation process? And when we're talking about implementation process, some helpful questions might be, is implementation being guided by a specific implementation strategy or process models? We might remember that implementation strategies, yes, can be derived from the ERIC taxonomy or behavior change techniques. They can also be protocolized approaches to implementation strategies. What are the components and features of that implementation strategy and the implementation process itself? And then again, going back to what we talked about in defining the innovation, what is the boundary between the innovation and the process or strategy being used to implement that innovation, right? And we really think about them. We're going to say it again to help remind ourselves that in the CFIR verse, we think about this boundary as being what stops and what continues. So, right, in thinking about the implementation are the things that stop the implementation process, the strategies are likely to end, but the innovation, right, the goal is sustainment, the goal is sustainability, the innovation continues indefinitely. And so if folks want to put in the chat, going back to our example, you might have to scroll up a little bit again to remind yourselves what would you say is the implementation process that we have in our example? Okay. All right, other folks? All right, do we want to go to the next slide and we can talk a little bit about this here? Yeah, so we define the implementation process as getting to outcomes. Getting to outcomes is a 10-step program for implementing, evaluating, and continuously improving prevention programs. Who it'd be helpful to know who is familiar with getting to outcomes, because I know this is another thing that is very common in some circles and really not known in other circles as well. Okay, not very familiar with it. Okay. I thought maybe that might be the case. Okay, all good. So, when we think about implementation strategies, just taking a bit of a step back, right? Implementation strategies can be discrete strategies. They can be multifaceted or multi-component strategies. Sometimes you have a strategy bundle. And then oftentimes you have, or at times you can have a protocolized strategy. And getting to outcomes is an example of a protocolized implementation strategy that was developed by one of our colleagues, Matt Chinman. And so what we will want to think about, I'm going through some of the responses here, is really differentiating between what are the things that we want to continue. So if we're thinking about the intuitive eating class continuing beyond that implementation effort at the beginning, things like the intuitive eating book, teaching the non-diet self-care, eating framework, right? Those are things that we want to continue. And so as we think about how we define them, they are part of the innovation itself rather than the implementation process. And so when we think about the implementation process as helping to guide analysis, it can be really helpful to clearly define the innovation versus that implementation process, because it allows us to accurately attribute outcomes, right? Was the barrier related to the innovation itself? So then maybe the innovation was poorly designed. Or was there a barrier related to the implementation process, right? Maybe the implementation process was poorly planned. Or in the case of a project where they had an external implementation facilitator, maybe the facilitator did not provide enough support or the type of support that the local folks needed. And so distinguishing between these two, I know, it may be like, okay, LauraEllen, you had the examples, so it's really easy for you, right? This is easier said than done. But really, we want to think about the innovation. One way to think about it is that innovation being the activities that we want to have continue indefinitely, and implementation as the activities that might end when implementation is complete. Often, this may be related to a grant funding cycle, for example. And so we have found that it's particularly difficult for users to define the implementation process domain when there isn't some externally facilitated or formal implementation process or strategy in place. And so often this can be in, larger quality improvement projects or more organically derived kind of implementation strategies. And so externally driven implementations often come down as policy and kind of like, good luck, hope it goes well. However, that doesn't always mean that that when you go to collect data that you won't hear from folks teaming, planning, etc. in the inner setting. And so generally the constructs in these domains have been roughly mapped to plan, do, study, act. Are folks familiar with PDSA cycles and the PDSA model? It's something that comes from the QI world. And you can think of them as aligning with any kind of generic process model. We might think about EPIS, for example, that guides the steps of implementation. So regardless of what you're implementing, these are included in CFIR because these activities, doing them, but also the quality of them influences implementation outcomes. And so, you mentioned EPIS. Thank you, Caitlin. I didn't see that in the chat. All right, so we're now going to go to questions about defining the CFIR domains. We have a little bit of time here. I know we've had some time answering questions already. So do we want to go to the next slide? And then we can answer a few more questions before we get into CFIR outcomes. So what questions do you have about defining the CFIR domains?
We actually have a couple I want to circle back to before
Oh,
we take
please. Yes,
more.
thank you.
So I just wanted to comment on Shelby's comment in the chat, which listed some of the like a specific processes, right? Like we're going to advertise for the class, we're going to evaluate. And so those activities map both onto the constructs in CFIR as well as our common steps in these different process models. And so I just wanted to say that when implementation is being guided by some type of specific process model, what we recommend is taking and doing a mapping between the steps in the model. So for example, there's 10 steps in GTO and mapping those onto the constructs, because that way you're able to sort of integrate that data collection. And then I wanted to respond to, I feel like Amy kind of caught us in our quick and dirty, the line is what goes on forever versus what ends. That is oversimplified, most definitely, because there are certain, implementation processes, right, that we want to continue forever, right? If we have new providers come on, we need to continue efforts to engage them in order to have them refer. And so it's a blurry line. And another way I've started to think about it is almost thinking about, form versus function, or, adaptable versus core components, where we don't necessarily maybe care as much about the processes that are used to engage, but we do need to make sure that folks are engaged. But the thing that we want to really continue forever, right, is this class that's based on the book, is, following the protocol, which is the 10 sessions, et cetera, et cetera. Somebody else had
And
commented, would the book be part of the innovation? Most definitely. That's sort of core.
yeah, and
Um,
maybe Caitlin, I'll just jump in briefly on that point. I think I have found in some situations where, for example, if we're using audit and feedback as part of our implementation process initially in the initial introduction of that innovation, but then we find that, for example, I was on a big hybrid type 3 trial, which is a bit of jargon there, but just to say a very large trial testing implementation strategies in the VA. And what we found was that for a certain innovation, surgeons really responded well to the audit and feedback strategy. And so when the formal kind of implementation process was ending, that audit and feedback process was almost built into the innovation itself. And so when new sites want to implement the innovation beyond what we were testing, our recommendation to them is, specifically with surgeons for this scenario, and there are lots of kind of like surgical cultural reasons that we can get into why audit and feedback works well for surgeons. But just to say, right, we would recommend to them, not only do you need to do these core components of the innovation as it was originally described, but we also recommend using audit and feedback. And it kind of becomes strategies at a point kind of become part of the innovation. And maybe they're more of an adaptable component of the innovation, but they go from being part of the implementation process to the innovation itself. So I think perhaps it's just another way to think about what you said, Caitlin. Very much agree with you.
I'm obsessed with that example. I want to steal it for the future. Don't worry,
You
I'll
may
cite you.
steal it. All good.
But yeah, I hope that answers it. It is blurry, and 100% what LauraEllen said. I think sometimes these things that we think are strategies become also routinized and institutionalized, right? If we know that they work. So I think for us, and obviously, right, with hybrid trials, you're often collecting data on context, on strategy, and on the intervention. And so, really, I think the important thing is that you're clear when you're coding about what they're talking about, if it's about a strategy or if it's about the intervention, just so that you know where you would need to intervene, right? Do you need to change something specific about the class? The book is not good, or do we need to change, we're not doing audit and feedback anymore. So I think the important thing is just to know kind of like what you're coding. And that was one of the big questions we got with the updated CFIR. It was, Is CFIR intended to evaluate the innovation or the strategy being used to implement the innovation? And at the end of the day, CFIR can be used to implement anything, right? Which very well may be a strategy. I've started to think about like the line between intervention and strategy is almost, where we is like based on where we're measuring. So, all that to say that, you can use CFIR to understand barriers and facilitators both to the intervention and the strategy, but you got to be clear about which is which, because otherwise I can't imagine the mess that your sort of data collection would, where it would go. Amalia, there are questions we have in the CFIR construct example questions. We do include example questions for the process domain. And people then, though, need to adapt. Oh, LauraEllen already put it in there. So, yeah.
Healing and sustainment.
Oh, I love that question, Derica. Especially sustainment. I'll say that when I've looked at sustainment determinant frameworks, I've never seen anything in them that isn't in CFIR. But there's always things that are in CFIR that are not in them that I think are relevant to sustainment. Some of the work that we want to do in the future is really to think about what constructs matter at these different phases. Intuitively, I can tell you that first domain, the innovation domain, those constructs seem in my work most relevant during adoption, right? Adoption decisions. Whereas once we're implementing, folks may be less concerned about, for example, the cost of the intervention. And I think that the same thing is true over time, that constructs sort of ebb and flow in their importance. I will say the Center for Implementation has done, or I don't know if they published it yet, but is doing some work to think about sort of temporality and constructs. So I highly recommend checking that out, but that's a great question.
I think some of these questions will come up in our next section if we want to keep going, or you're welcome to, we can answer them now.
How are we on time? I think, should we keep going?
I think let's keep going. I am copying down questions, and so we can make sure to grab all of these. So I am seeing them in the chat. So we'll pass it over to Caitlin. This is really wonderful participation, everyone. Thank you so much. Yeah, keep putting your questions in the chat, and we'll be sure to answer them.
All righty. So moving on, this is fun. I'm like, oh, I want to answer questions, but no, we're going to stick to the timeline, guys. So I'm going to talk about the CFIR Outcomes Addendum, which was a companion paper. It was actually published before the updated CFIR, but is a companion paper to the updated CFIR. In order to, complete the step one, right? So step one of the using CFIR and implementation research is defining our domains and then developing or identifying our research question and our outcome. And so in order to do that, we're going to go over the CFIR Outcomes Addendum. So what is the CFIR Outcomes Addendum? Overall, it's a tool to help users understand which outcomes are appropriate to use with CFIR, or rather which the constructs in CFIR, which outcome do they influence? So it clarifies the scope and purpose of CFIR by making conceptual distinctions between 1, CFIR-based implementation determinants versus innovation effectiveness determinants, 2, anticipated versus actual implementation outcomes, and 3, implementation versus reach versus innovation effectiveness outcomes. That last distinction, implementation versus innovation effectiveness outcomes, is usually relatively well understood, but not always. So briefly, when we're thinking about implementation versus innovation effectiveness outcomes, implementation outcomes are the success or lack of success getting that intervention into routine use in the inner setting, right? Delivery. Whereas innovation effectiveness outcomes are really about the impact of the thing on recipients. So for example, in this case, right, on our veterans with binge eating disorder. So let's go over the outcomes addendum fully. So first, I'll talk about innovation effectiveness outcomes. So these are focused on the success or failure of the innovation based on the impact of the innovation on three important constituents. One are innovation recipients, two are innovation deliverers, and three are key decision makers or the system, right? So in our current example, we could be thinking about the recipients as our veterans, as our deliverers, as our dietitians that are delivering the program, and our providers that are doing the referrals, and then our key decision makers as, our high level leaders within the inner setting. So when we're thinking about recipients, right, this is and outcomes, we're thinking about our typical clinical effectiveness outcomes. That's where those fit. The reason that CFIR, the outcomes addendum, highlights, thinking about deliverers and the system as well is related to sort of sustainability and equity, right? So if we think about implementing something that, really positively impacts recipients, right? Let's say this intervention is wonderful for veterans with binge eating disorder. But let's say it really negatively impacts or is even untenable for the registered dietitians to deliver or for the system to be able to afford over the long term, it's unlikely to be sustained, at which point we've wasted a lot of effort, right, getting it into place. So we hope by highlighting these three different constituencies that we implement things that are actually doable over the long term and take into account, everyone's sort of needs as we move forward. So second, I'll talk about reach. So in order for our veterans to be impacted by this intuitive eating class, right, they have to be reached. They have to actually come to the class. So we use the definition for reach from REAIM, right? So the absolute number, proportion, and representativeness of individuals who participate in that initiative, intervention, or program. I do want to note, CFIR includes engaging recipients as a determinant in the implementation process domain, whereas REACH as an outcome, we're thinking about it as the actual level of engagement or participation in the innovation. Third, I'll talk about implementation outcomes. So these are focused on the success or failure of implementation in the inner setting, right, or our unit of analysis. And we think about three broadly conceptualized outcomes based on REAIM and our own work. So adoption, whether the decision is made to deliver the innovation; implementation, whether implementation and delivery of the innovation does occur; and sustainment, whether the delivery of the innovation continues in the long term. We also distinguish between anticipated implementation outcomes and actual implementation outcomes. Anticipated implementation outcomes are prospective, and they represent the likelihood of future implementation success or failure. The most common one we ask about, right, is sustainability. Do we think this is a sustainable intervention, and why or why not? Actual implementation outcomes are retrospective and represent current or past implementation success or failure. So in this case, the example would be, did they in fact implement? Did they in fact sustain? I just saw Yashu's comment. Excuse me if I didn't pronounce your name correctly, but yeah, essentially when we're thinking about implementation, I will say my personal favorite outcome is fidelity to the implementation plan. Is everyone doing everything as they should in the inner setting, being that focus on delivery.
Caitlin,
Yes.
maybe just a quick point there. You're thinking about fidelity to the implementation plan as being distinct from fidelity to the innovation itself.
I would say it's a blurry line. I think the conversation about implementation fidelity versus treatment fidelity gets sort of blurry. And so I've almost wanted to move away from using that word and just saying exactly what I mean, which is that the innovation is being, was implemented and is being delivered as intended. When it comes to, all of the core components being delivered, all of the sessions, et cetera. That is our sort of like long-term goal of, is this happening as intended? So a big thing when you're using CFIR, right, is to remember that inner setting is your unit of analysis, and that's where implementation is being assessed, not at the recipient level. The field has sort of blurred and grown, and sometimes we start to think about and define implementation at the recipient level. When you're using CFIR, it's very much at that organizational level. So fourth, I'll talk about antecedent assessments. Those are above the implementation outcomes. So Proctor's outcomes for implementation research lists acceptability, appropriateness, and feasibility as implementation outcomes. And while these measures can be used to predict any anticipated or actual implementation outcomes, they don't measure the actual success or failure of implementation in the inner setting. And so we classified those in the addendum as antecedent assessments, which followed Catherine Riley's 2020 work. In addition, if you're familiar with the original CFIR, it used to list implementation climate and implementation readiness as sort of parent constructs or higher order constructs in the framework, with each comprising multiple determinants. Those are very similar to those items in Proctor. And so as a result, we also classified those as antecedent assessments as well. They're sort of measures that are being influenced by constellations of CFIR constructs that then go on to influence implementation success or failure. Fifth, I'll talk about the temporality and relationships between the different types of outcomes. So in the figure, those right-facing arrows at the top illustrate the temporal nature of 1, anticipated and actual implementation outcomes, and 2, implementation outcomes and innovation effectiveness outcomes. The right-facing arrow between anticipated and actual implementation outcomes illustrates the sort of generative nature of anticipated outcomes, right? What we think may happen is oftentimes more likely to happen and shapes our behavior. The right-facing arrow between implementation and innovation effectiveness outcomes illustrates really just the foundational premise within implementation science that successful implementation is a necessary precondition to achieving those maximum innovation benefits. So for example, an effective innovation will fail to produce expected outcomes if it's poorly implemented. That might result in a type 3 error when evaluators conclude the innovation is ineffective, when in fact the same innovation may have met or exceeded expectations if it had been properly implemented. The left-facing arrows across the bottom of the figure illustrate the reinforcing loop that can emerge when the positive impact of innovation inspires continued commitment to implementation and sustainment. Last, I'll talk about implementation versus innovation effectiveness determinants. So CFIR implementation determinants capture those inner setting level barriers and facilitators that predict or explain those antecedent assessments and or the anticipated or actual implementation outcomes. So data on those determinants is best collected from individuals who have influence and or power related to implementation in the inner setting. So those typically include those key decision makers, as well as individuals implementing or delivering the intervention. So as a result, CFIR is actually not the most appropriate framework to use when you're collecting data from recipients, or in our case, right, patients, unless those recipients are also helping to implement or deliver the innovation in the inner setting. We've seen some movement towards, more shared decision making especially in hospitals, but those efforts haven't really resulted yet in true power sharing between recipients and key decision makers. As a result, direct data collection from recipients usually can't speak to, the delivery and implementation or those outcomes in the inner setting. Instead, it's data collection from key decision makers and, our implementers and our deliverers about their perceptions of recipients, right? And we talked a little bit about this already, and then how those perceptions encourage or discourage completing implementation. So if our deliverers or our referring providers don't believe that this intuitive eating class will in fact meet the needs of recipients or veterans, why would they bother to refer? Although CFIR is often not appropriate to use with recipients because they're not holding those key roles in the inner setting, our CFIR leadership team really hopes that will change, right? Recipients should have greater influence and power in these systems. And the updated CFIR highlighted the importance of when you're going about, implementation in that process domain, including innovation recipients, as well as innovation delivers, right? They're often also excluded from the implementation planning process. And when they serve in that role, then using CFIR to collect data about implementation determinants, makes complete sense. And at that point, we are more likely to have, right, our equitable population impact. In contrast to implementation determinants, innovation effectiveness determinants capture those recipient level characteristics and their perceptions of the intervention that predict and or explain innovation effectiveness outcomes. Data on those determinants, right, is best collected from recipients. Those determinants include often characteristics of recipients as well as their perceptions of the intervention itself. Although sometimes you even want to do a deeper dive into your intervention, right? If there's an underlying theory of your intervention, it's very likely that there are determinants within that that you want to ask about, right? If self-efficacy and motivation are important components, those are things that you would want to be talking about or are determinants to that effectiveness. CFIR wasn't designed to capture those types of determinants, those innovation effectiveness determinants. And adapting CFIR for those constructs, which people do, ultimately separates them from that underlying organizational theory. So it's not recommended. So interestingly, you'll note that both how we conceptualize this, both implementation and innovation effectiveness determinants influence reach, right? So to reach recipients, you need to have done a good job implementing, and you need to have a good intervention. You need to have something good for them to show up to. But overall, CFIR determinants primarily influence those antecedent assessments and those implementation outcomes in the yellow box. I will say we conceptualize reach as distinct from implementation outcomes in alignment with the REAIM developers and the REAIM outcomes cascade that was published in the 2024 paper. In that conceptualization, reach follows or precedes implementation, right? That fidelity to the elements of the innovations protocol, and precedes innovation effectiveness or the impact on innovation outcomes. In other words, effective implementation is necessary but not sufficient for effective reach. And effective reach is necessary but not sufficient for innovation effectiveness. So in order to fully understand reach, we need to be talking to recipients as well and hearing from them directly about what they, why they did or did not participate and why they did or did not benefit. We do, though, recognize that given the diverse types of interventions and contexts being studied, that sometimes reach is our best option and or simply a proxy for the initiation of implementation. So overall, we really recommend people finding, outcomes that are proximal to implementation and delivery when using CFIR. So remember, if you're using CFIR, you probably shouldn't be using it to collect data from recipients. There are more appropriate frameworks for that use. So we'll now finish the CFIR and study design activity by working together to define a research question and outcome. But first, let's think about the kinds of research questions that CFIR can help us understand. So, and this actually was a question I saw about using CFIR, pre versus post. CFIR can be used both prospectively and retrospectively, right? It can be used to assess determinants to anticipated outcomes, right? Outcomes that haven't occurred yet, or retrospectively to assess determinants to actual implementation outcomes. And most projects use CFIR both. They use it prospectively and retrospectively, and often even during the implementation process, right? We see that's where often mixed methods come in, where folks might be doing a baseline survey using, archival data like meeting minutes during the implementation process to track what's going on, and then maybe at the end doing some interviews, right? So you have that that flexibility when you are using CFIR. So with our example, right, and maybe we can get the, LauraEllen, could you put the example in the chat again? What would be a relevant implementation research question? And also a measure. I will say when we think about, or outcome and measure, we think about outcome as really broad, right? Are we thinking about adoptability, adoption, implementability, implementation? And then measure is how are we actually going to measure that outcome? And so if you can put in the chat, let's start with what would be a good implementation research question to understand using CFIR. And I'll just flip back to this slide. To show those example research questions. Yeah, I'm liking what I'm seeing. So yeah, what are barriers and facilitators, right? We can ask that question generally. Yeah, Martha, I like yours as well. So some people are looking at barriers and facilitators to implementation. Some are thinking about adoption. We didn't specify in our example the temporality, and so either of those are appropriate. Another really common question that people have when they're doing analysis with CFIR is not only the general sort of barriers and facilitators, right, to those implementation outcomes, but also what are the barriers and facilitators that are difference makers, right? What are the constructs that actually distinguish between, let's say, hospitals with low success versus high success? In that sense, let's say, we have one hospital that, ultimately only does half the sessions or, does them poorly, something like that. And then we have a hospital that, implements quote unquote perfectly. Another research question would be like, why? Which of the constructs are starting to matter, right? So that's perfect. All right, so let's say we've decided we want to measure implementation from your guys' questions. What would be a way to measure that in this example? So just go ahead and put that in chat. How would you all want to measure implementation? Okay, awesome. All right, let's go to the next slide. So here is our answer. We already talked about the question. Our outcome is implementation, and the example that we gave here was a fidelity checklist score, so adherence to the IE class protocol. I saw some other really good options in here. So referral rates, so Hannah, that's great. Referral rates, I would say, gets at one part of successful implementation. And it is super important, right? Because if the providers don't refer anybody, then we can't implement anything. So what I really like to think about is like, what are all the things that need to happen, and then figuring out how we can measure if they did in fact happen for implementation and delivery. So yeah, an implementation checklist I think can be really similar to a fidelity checklist.
And Caitlin, one of the things I think about that as well is as you think about the sequencing of your innovation, in the similar way to the REAIM cascade. Caitlin has now gotten me into the REAIM cascade. Big fan now. But it becomes kind of a similar process of identifying where are people dropping off. So are people being dropped in that referral process? Is it something about getting enrolled? Is it something about showing up to session 1? Or is it, hey, we got through session 7, and then maybe something happens after session 7 that people are like, yo, I'm out of this. I'm done. I'm done with this class, right? And so I think having those fidelity checklists with each sequence step of your innovation can be really, really powerful for thinking about not just fidelity as a fidelity checklist as a measure of implementation, but where and who are dropping out at various points in your process. So just to build on a bit more of what you were saying, Caitlin.
I love that. We've been working on, it's been a little bit sidelined because projects and life, but really thinking about, we call them the 5 Ws, right? Who, what, where, when. And thinking about defining, success in terms of that pipeline of, at every step, right? is the person that's supposed to be doing the thing every time, everywhere, right? That they're supposed to be doing it. It sounds very silly saying it that way, but it helps you identify where the gap is, right? Is it all providers are referring? It's just that they're doing a horrible job describing the class, or providers are referring, but only to certain patients, right? Not to all of our eligible patients. Providers are referring, but they're only doing it after lunch when they are, not hungry, things like that. So just trying to understand and then measure, right? And I'm not saying it's hard, right? It's really hard, especially without being able to do observations, which have become, at least for our team, harder and harder. So I noticed I wanted to bring up this slide. This is a slide we like to sort of be thinking about how what these different types of outcomes might look like, because identifying like an appropriate and measurable implementation outcome is so hard. It's hard to conceptualize, and then it's hard in terms of feasibility, right? Of finding something that you can in fact measure. But our goal and like what we promote is this idea of like wanting the measure to be as proximal to those implementation efforts as possible. I saw somebody in the chat say like, is this too far downstream or down the line? And, if you're questioning that, maybe, yeah, probably it is, right? Which doesn't mean you shouldn't also be measuring that, right? Almost every study we see now is some type of hybrid where you're going to be measuring potentially multiple measures for reach, multiple measures for effectiveness. But this slide just shows where we would be, like what examples for each of these might be as measures. So earlier somebody mentioned ORIC, and I used to be familiar with that. I'm less now, but for example, the ORCA score, right, might help you assess as an antecedent assessment the level of readiness of the organization. If you wanted to measure implementability, right, that's a tricky one to measure. It's hard to measure something that hasn't happened. But we, for example, have this example interview question that we use where we define successful implementation, right, which is in what we're just talking about, right? In this case, it's, providers sending referrals, registered dietitians offering the class, et cetera, et cetera. And then we just ask them to rank it, right? For them to be thinking about, yeah, can we do this or can we not do this? When it comes to the actual implementation, the example we used, right, it's a fidelity checklist score. But, that might include, are folks doing, but that might also include, like, are these primary care docs referring, every veteran that's eligible, every veteran that has this diagnosis of binge eating disorder. When we are thinking about reach, we're thinking, okay, did they actually show up, right? Did they attend, let's say, 7+ sessions? That's just an example. Maybe you want to measure reach at, one session. Maybe you want to measure it at 5, 7, 10, et cetera. When it comes to these final innovation effectiveness outcomes, when we're thinking about our recipients, right, we're thinking about seeing a reduction in binge eating, right? Or maybe we're looking at an increase in that scale that the example includes, right? The intuitive eating scale. For innovation deliverers, we're hoping, honestly, to just not make them miserable. That's how I like to think about it. But maybe the offering this class really increases their work satisfaction. I saw that happen in a study with VA where they were implementing moral injury groups, and it was such a sort of profound and meaningful experience for these deliverers that they had this truly just like renewed sense in their work, right? That's best case scenario. Hopefully we just aren't making them completely miserable by adding something else to their plates that they don't have time for. And then last but not least, for our key decision makers or our system, right, we're hoping for a positive return on investment, or at least something that's budget neutral, right? We don't want something that's so expensive that we can't actually, sustain it in the long term. So that's sort of how we conceptualize those things, right? And going back, we can see our CFIR implementation determinants at the top, influencing, mostly the things in this yellow box. We can see how reach is being influenced by both, it's kind of in the middle, getting, this line is blurry, right? These types of determinants. And then last but not least, our innovation effectiveness determinants impacting our effectiveness outcomes. And again, when we think about innovation effectiveness determinants, I'm thinking about talking to patients about their experiences, their perceptions, their competing demands, et cetera, as well as measuring their demographics, right? So we can understand that. Okay. So now this is our second Q&A. It'll be specific to this section, these research questions and outcomes, and then we'll have another final Q&A that's just go crazy, super broad. I did see that there was things happening in the chat, but I wasn't able to track it. So I don't know if, LauraEllen maybe knows things that were.
Yeah, I think some of the things we were able to address. Let's see. Questions related to outcomes. Someone had the question, if I am trying to retrospectively evaluate implementation, but have it defined as whether the workshop was delivered as intended to at least 20 participants at the inner setting, is my outcome actually reach? Or would you consider that implementation?
Could you say it one more time?
Yes. Trying to retrospectively evaluate implementation, which is defined as whether the workshop was delivered as intended to at least 20 participants in the inner setting.
Oh, and they're asking, is that actually reach?
Is that reach or is that implementation?
Yeah, it's so interesting. Oh gosh, is it time to bring out the hug analogy, Laura
I
Ellen?
know. A little peek behind the curtain. Caitlin and I have had one of the most interesting intellectual debates I've had in quite a long time about is reach an innovation effectiveness or an implementation outcome. And I think we kind of came to the conclusion is that it really depends. And I think it is so complicated. Yeah, Caitlin, if you I love your hug analogy, so if you want to bring that out, that may be helpful for folks as well.
Um, so I I've started thinking, I mean this sounds silly, so just forgive me. But I've started to think about implementation, right, as offering a hug. But if there's no one there to receive my hug, then a hug does not in fact occur. In the same vein, right, if Laura Ellen, let's say, is the huggy in this case, right, if she's standing there waiting for a hug and I don't offer one, then again, a hug has not occurred. And so I think about myself as the implementer, right? I need to be offering the hug and offering it well. But Laura Ellen also needs to be open to receiving that hug in order for these things to happen. And you end up seeing this cycle, right? Because we need to refer well, right? We need to do shared decision making, talk to patients about why this class might work well for them. They need to show up to the first class, right? So the referral, implementation, the person showing up to the first class, reach. Okay, now the registered dietitians need to offer this class well, right? According to the protocol, but also with compassion and kindness and building rapport and trust. That hopefully implementation means that people keep showing up. And it becomes this like cycle, right? Because you can't implement to an empty room. But at the same time, there's a lot more going on for patients that's influencing whether or not they show up and can be reached than how good of a job we're doing with implementation, right? Because the world is big and our sphere of influence is, ends at a certain point. And we have to be thinking about and talking to veterans in this case about, do they have transportation barriers? Are they motivated, et cetera? We wouldn't use CFIR to do that, though. Actually, I noticed something in the chat about barriers with veterans. With veterans, right, would really speak to why they're being reached or not, why they are sort of maybe adhering to or following the guidelines of the class, right, and why they then benefit or do not benefit. So anyway, that's the sort of hug analogy. It is tricky, but our big thing is just that if you are wanting to measure reach, talk to recipients as well. Just hear from them directly, right? Because I almost think reach is like the problem child, right? There's a lot of different types of determinants influencing reach. And so with that question, that example, I think it'll be very important, right, you could use CFIR. I mean, I think you should use CFIR to understand if that class, was offered, delivered, et cetera, as intended, if those referrals happened. but making sure you're talking to patients too about ultimately, why those 20 people did or did not, show up. So
Yeah, and
it's really
and
the thing I think we care the most about.
yeah, and I think, one additional kind of point to this is many of our examples here, the innovation recipients are patients. In some cases, for some of our innovations, the innovation recipients are clinicians, right? And so and again, this is where like I said, Caitlin and I had a very intellectual, fun debate trying to figure out kind of how we thought of this and recognizing that implementation happens in all areas of life, right? In education, in justice settings, in social services, and healthcare settings as well. And also recognizing that implementation happens at many different levels. And so you may be implementing at the hospital level or at the organizational level, and then those recipients of your innovation are clinicians themselves. And so, really thinking and operationalizing, I think that's why we started and very intentionally started with defining your domains. Really thinking about what is your research question, defining your domains, what is the information that you're trying to understand and trying to unpack. And then, in that way, hopefully, some of these additional definitions will make a little bit more sense. And we will share contact information. And of course, any of you here at Penn or as part of the Improve Network or as part of the VA can get a hold of me. And Caitlin's information is available as well. So it gets very tricky and very complicated. And so yeah, reach out for help, like ask around, look at other studies and how they've done things, and then do your best, right? Like we're all trying to close this larger evidence practice gap. That's why we're doing this. That's why we're doing this work. And so just know that it's a little complicated at times. All the time, maybe? Yeah.
Yes. I was
Yeah.
just, I responded to one chat. This is going to sound so, I cannot figure out how to reply to people. So
Oh,
I can quote and then or I just can at them. But anyway,
okay.
I just quoted somebody. Um, but basically, I think there's this confusion that happens where when we say you shouldn't use CFIR with patients or recipients, that we think that you shouldn't talk to patients at all. And that is 100% the opposite of what we think. It's just that if you look at the constructs in CFIR, they don't make sense when you're talking to patients because it's all at the organizational level, right? It's like if you're talking to a veteran, like, well, is this compatible with your doctor's workflow? I mean, they might have an idea of it, but usually not super, super well. Whereas they're going to be able to speak to their own life experiences, right? And why they show up, why they participate, why something worked. Ultimately, that information gets fed back in to implementation processes and hopefully improves things. But it's really just about like where CFIR fits into this process. I was looking at more questions.
Yes.
And yeah, I guess it's 1:40, so we can kind of just do
Yeah.
all questions. So
Do you want to share our contact info so that
yeah.
people can grab it?
So I'm looking at the question about matrices and quantitative ratings. I think it's going to depend on what your goals are. And we do say that you typically need to have at least 3 sites in order to make ratings worth your time. But if you want to identify difference maker constructs, then that's typically the best way to do it.
Yeah, and in the user guide paper, we worked on some rating guidance for that using the CFIR domains and constructs. Caitlin and I actually spent a lot of time. That was one of our primary activities for that paper was working on that ratings matrix, and so there can be some guidance there for you as well.
Then there's a question, what if the recipients are co-designers and adaptation of an innovation? Can you use CFIR? So I'm assuming you mean then like to understand implementation. Um, So, and, barriers and facilitators to that. So yeah, at that point, it does sound like recipients are more involved or being brought into the inner setting. So what we say is if recipients are included on the implementation team, right? If they're at the meetings, right? Then they are more likely to have that window. Those individuals are more likely to have that window into the inner setting, and they're another key informant just like anybody else. But it's really, we like to think about it as, being part of implementation, maybe not so much adaptation, although it sort of depends on what you're asking. But basically, if they're being brought in and they are now a key informant about the inner setting, then most definitely.
Yeah, Caitlin, Ritu had two questions, one from earlier that I wanted to highlight, and then one more recently. So, um, she said, I had a reviewer state that since my study employed the CFIR framework to guide both the development of the interview questions and the subsequent data analysis, such a deductive approach was a form of bias. However, we did add and modify constructs in the coding process. Is this still a valid criticism, and how would I respond to the reviewer? I have never heard of that in my life, but you've done more qualitative work using CFIR than I have.
Wow. So it's so interesting. I'm in such a qualitative bubble that I forget that that's not the whole world. And I want to share, LauraEllen, with them the paper that Andrea just published.
Yes.
I
Let
don't
me
think she
find it.
speaks specifically to that, but basically it's a paper that has sort of debunks 10 myths when you're trying to publish qualitative research. I wouldn't even, I mean, I will say when we are using CFIR, we do recommend both a deductive and inductive approach. By that I mean, go through the constructs, select the relevant constructs, but there might be other things, right, that you need to ask about. So certainly include those. When it comes time to coding, right, we recommend looking at all the constructs for coding, but there's always going to be gaps in CFIR, right? And so you're going to want to be adding constructs as needed to capture those new themes. Um, I don't even know how to respond to that. I mean, the whole point of and like moving towards like deductive approaches, right, is that we're able to start to share a common language to advance the field. So I don't know, it makes me wonder what that person's background is. I'd have to think more about how to respond because it feels kind of like a bananas comment to me. So sorry.
Yeah, and one additional question. Qual papers and qual papers using CFIR tend to be very long. Do you have suggestions on how to present results besides in tables in ways where we don't overwhelm readers, reviewers with manuscript length?
Well, I will say that's another benefit of identifying those difference maker constructs. So for example, with a manuscript that is quite old at this point, but it's a good one for like understanding the CFIR process. In the main body, in the results, we only included data or information about those difference maker constructs, but then described how the other constructs were showing up that weren't difference makers in an additional file. So I will say our team, we love additional files. I mean, we had 6 in the user guide. So I just say additional files if you have to.
Yeah, I'm also a big fan of additional files. Another question. I have noticed that some of the CFIR questions can feel very jargony / strange to providers that are not as familiar with implementation science. Wondering how you think about that as you develop interviews, and I'm assuming interview guides.
Oh, yeah. I mean, so we say at the top of our example questions that these are just examples to help people understand what the construct is intending to get at. And the people that we find are using that, right, are developing those questions are in fact the people that, do have that familiarity, but then are hopefully there's people on your team that have, more background, more clinical background, et cetera, to really help you adapt those questions, right? To use language that's appropriate based on the intervention, based on your participants, based on the time period, the temporality. So we're very clear that those are just example questions to get at underlying core meaning of the construct. But you definitely want to adapt those. One thing I'll say we've learned from teaching CFIR Academy is that we recommend when you're adapting questions, also looking at the coding guidelines, because we noticed that sometimes when folks were adapting questions, they were adapting them to the extent that it then mapped to a different construct. So I would say sometimes looking at the inclusion and exclusion criteria in the coding guidelines for developing questions can really be helpful to get like a deeper dive or deeper understanding of that construct. In addition, obviously, to the detailed descriptions, which are in the manuscript and also online.
Yeah, Caitlin, another question. Updated guidelines for rapid qualitative analysis using CFIR, recognizing the 2021 paper that you and Andrea. Is there updated guidance on that since the updated CFIR has come out, or it's the same kind of process but using the updated CFIR?
It's the same process. You can actually use that approach with any framework.
Awesome. Can you tell us more about the CFIR Academy, Caitlin?
So CFIR Academy, we have a VA query learning hub, and we will be launching our second cohort in May. It's a 5-week. No, it's 5 2-hour sessions that are every other week with office hours in between. So it's a total of 10 weeks. And we basically do a deep dive in each of the steps that are in the CFIR user guide. And I will say that we do have to prioritize VA learners, but we have been able to, in the last 2 cohorts, include some non-VA learners as well. If you have a VA affiliation, though, I mean, even better. In fact, we can, if anybody's interested, just send me an email, because that we have a couple spots actually open on that current cohort. So I could give you the flyer that has the dates and things like that. So yeah.
Yeah, and just to say that we recognize that because of our funding for that, we need to prioritize VA affiliated folks. We also realize that there is need for CFIR training outside of that, and so which is one of the reasons why we did this session. We have a couple other externally facing sessions. This past year, we did a workshop at the Academy Health D&I conference. I don't know if we'll do that or some kind of adjacent meeting again in December of 26. We haven't talked about it. So, but just know that there are other opportunities as well. Caitlin, I'm trying to scroll back through and get all of the questions. If we have not gotten to your question and it's still pressing for you, please repost it to make sure that we're getting.
And I answered one in the chat, and then I'm seeing Amalia's about triangulating recipient interviews with context inquiry related to CFIR. So yeah, 100%. And also what I really like, we have a paper that was about it was an evaluation of the VA diabetes prevention program. But what I think most hybrids, right, are going to be presenting results on essentially all of the re-aim outcomes or related outcomes. And that provides you an opportunity, right, to include data from all sources in a single paper potentially, right? So you've got sort of like data about your determinants related to implementation, reach, and effectiveness. What I think is also interesting is that while recipients often can't speak to determinants, right, that are in CFIR, recipients can often speak to implementation effectiveness or their experience of it. So let's say, for example, you go and you do a fidelity checklist and you witness, they did all the sessions and they followed the book and, the person had good rapport, et cetera, et cetera. Then when you go and talk to recipients, right, what is their perception of the quality of delivery, right, of rapport with the facilitator and things like that. So where I really find it interesting to triangulate is with those with outcomes, right? With their perception of outcomes, because their perception of the quality of implementation is the thing, right, that goes on to then influence also reach and effectiveness. So I'm not sure if that answers it, but I think there's kind of two ways to combine your data.
And I posted that citation in the chat for you, Caitlin. Yeah, and feel free. I put my email in the chat. Feel free to email me. We're meeting the CFIR leadership team, who also runs the Learning Hub, is meeting on Wednesday, so I can pass your information on to our wonderful support Jennifer, who keeps us moving. Other questions that folks are having. I'm continuing to scroll back here, Caitlin.
Me too.
One new. Thank you. Yeah, thank you all so much. Yeah, other questions that folks have. Caitlin, are there other reflections that you have as someone who has worked with CFIR for a really long time, who reviews and consults on a lot of different CFIR projects? What are some like key takeaways that you want people to know as they're thinking about and as they're using CFIR?
Oh, wow. I would say that, we've published an enormous amount of information and guidelines between the updated CFIR, the outcomes addendum, and now the user guide. That user guide, like I said, has 6 additional files in it. And so often we probably do have an answer to almost every question between those 3 manuscripts. And so I think that doing a deep dive, if you're wanting to use CFIR, and reading those all carefully is super important. And then reaching out to us for sure, because we love getting CFIR questions. And typically where those questions come up is then when you're trying to operationalize all the guidance that we've given. And it's at that point that, we can help, but also really thinking critically, working with your team. I think that, it's interesting. CFIR is often, kind of critiqued for being like too complex. And I'm not saying it's not complex, but I do think that implementation is complex. And I think understanding implementation is very complex. And so really, I think that CFIR sort of gets blamed for the complexity of just the work, right? The work, which is very, very tricky. And so it really does require, thinking critically and doing that deep dive. Yeah, not rushing, I think, even though, we are all rushed. So I think that would be my thing. What would you say as more of like a person that's new? As a person that's new and is also embarking on like a meta CFIR project, which is
Yeah,
very brain
yeah.
hurting.
Yeah, I've been working with CFIR for a long time, not, definitely not to the way, and I come to this work from a theory-based perspective, and so and use a whole lot of theories, models, and frameworks. And I think that your point about the complexity of CFIR is well made, and I think we don't do anyone we do a disservice to ourselves, to the people for whom we are trying to do this work, the outcomes that we're trying to change, if we oversimplify things. There's a difference between making things accessible for folks, which is, what we're trying to do with this workshop, and oversimplifying and stripping things of the nuance and the complexity and the richness that exists within these settings, that exists within implementation processes. And so absolutely, I think my encouragement is very much the same, to take your time to, it sounds a little, trite almost, but put on your critical thinking hats, right? Like really sit and think about these things. Life is complicated. Healthcare is especially complicated. And we are okay with complicated. We are okay with nuance, and we can figure out ways to close these evidence practice gaps, right? That is our goal, to do that in a way that is equitable, that is just, that's reaching the people who need it the most. And so, Yeah, I mean that is the passion, that's the mission that I do all my work with, but I think especially with CFIR, there's so much information out there, and so taking the time to dig into that is really, really important. Um, all right, well, I think we're going to close out. Thank you all for such the lovely responses. We will put together the recording, a PDF of the slide deck, and send contact information so that if folks are interested in the academy, the CFIR Academy, you can kind of get on the list for that and find out more details about the requirements for that. Caitlin, thank you so much for joining us here at Pisces, joining us here at Penn. If but virtually, someday we'll bring you to Philly and we'll hang out and have a day together. But yeah, thank you all so much for coming, and please reach out with additional questions. Thank you.
Definitely. Yeah. Thanks so much for having us.
All right, see you
Thank you
later.
so much, LauraEllen and Caitlin. This was a fantastic talk. Really appreciate you doing it. And thank you all for attending. Thanks
Bye.
so much.